جدا وسبيكر كمان متميز، دكتور عمرو عبد الحميد هيتكلم عن الكريزيكان The New Ultimate Solution for Relieving Atopic Dermatitis.
بشكر حضراتكم الحضور الكريم، بشكر طبعا المنصه الكريمه، استاذ الدكتور رمضان صالح، استاذ الدكتور وفاء عبد المجيد، استاذ الدكتور وليد مدحت، تشريفهم وتنويرهم لينا. بشكر طبعا شركه الحكمه على السبونسرنج السيشن دي. النهارده هنتكلم عن نيو تريتمنت اوبشن عندنا في التريتمنت اوف اتوبيك ديرماتيتس، لان الاتوبيك ديرماتيتس ده كرونيك ديس اوردر زي ما ليتر اون هنشوف. بس في ديكلاريشن كده حابب اقوله ان الداتا not related to حكمة products may include medication not yet registered in Egypt or with indications that are not yet approved, and the content is the responsibility of the author, me. So our agenda today, we will discuss brief introduction about atopic dermatitis epidemiology, its summary of its pathogenesis, and how this new emerging treatment modality, which is a BD4 inhibitor, can be used safely and effectively in patients with atopic dermatitis, and the comparison of this BD4 inhibitor in relationship to topical corticosteroid and the TCI topical calcineurin inhibitors. As we know, atopic dermatitis is a chronic inflammatory skin condition, and this should be counseled for our patient or our parents, because this is a chronic disorder. Usually we have a frequent exacerbation and remission, and the parents should be counseled about this nature of the disease. And because of this, we need to use a long-term maintenance or proactive treatment to reduce the number of exacerbation in this chronic disorder. It is the disease of childhood. About 15 to 25% of our patients of atopy in the childhood age, and this less prevalence rate from up to 10% in adult patient. So about 60% of our patients, they are below the age of 1 year. This is very common scenario to have a patient less than 1 year having atopic dermatitis, and this is make us very restricted in finding a good solution for treating such patient in such younger age. This is a very large multicentric study in Egypt. They estimating that the female adult patients, they have frequently more atopic dermatitis symptoms, and the prevalence of among Egyptian children, they are more or less equal to the general or international numbers from 10 to 12%. Also, we know that atopic dermatitis have been associated with severe itching, severe skin dryness, frequent eczematous eruption, and this will impact the quality of life of our patient, impact their sleep, and even their productivity and the social and the emotional. And because of this, we have a very negative impact of atopic dermatitis on the quality of life of our patient, and this is very important, should be considered when treating our patients. So what is the mechanism of action of Crisacan or crisaborole? We need to know briefly that we are facing a multifactorial etiology atopic dermatitis that's shared with epidermal barrier dysfunction, immunological abnormalities being mainly mediated through T helper 2, and to lesser extent in the acute phase, and to helper 1 in the chronic stage of atopic dermatitis, together with aggravating or exacerbating factor that should be mentioned and counseled for our parents, that excessive sweat, excessive heat exposure, and dryness of the skin. All these are exacerbating, and there is seasonal exacerbation of atopic dermatitis. This should also be considered in treating our patient. In atopic dermatitis, we have frequently upregulated phosphodiesterase 4, and this lead to decrease the concentration of cyclic AMP, and this lead to inactivation of protein kinase A, which is lead to upregulation of 2 nuclear factor of activity T cell and nuclear factor kappa B, which increase the inflammatory mediators that mediate the inflammation in atopic dermatitis patient. And simply, Crisacan come to inhibit this enzyme, the phosphodiesterase 4, and lead to increase the cyclic AMP, and lead to activation of the protein kinase A and the inhibition of the post-inflammatory pathways of nuclear kappa B and nuclear activated T cell. This is a table summarize also cytokine profile that can be inhibited by BD4 inhibitors, Crisacan, and topical corticosteroid and TCI. And we can see that the cytokine profile that is inhibited by the BD4 Crisacan is quite similar to that inhibited by topical corticosteroid. And in between, very little cytokines are affected by TCI, which already we have previous experience and we have been used for several years. Also, we can see that T helper 17 only affected by topical corticosteroid and Crisacan PD4 inhibitor. And this slide show all the stars have been added to the cytokines that been inhibited. All the profile of the T helper 2, interleukin 4, 5, 13, and even T helper 1 cytokine profile, interferon gamma and transform growth factor beta, and even T helper 22 and affection of the interleukin 22. All these cytokines can be blocked and inhibited by inhibition of the phosphodiesterase 4 by using Crisacan. So what about the clinical? Now we know the pathogenesis or the how it works, the BD4 Crisacan. So what is the clinical efficacy? Usually we have this common scenario. Girl, 5 years old, suffering from itching, redness, cheeks and the hand, her skin very dry and crusting, and diagnosed with moderate atopic dermatitis. Is Crisacan effective in such a patient? Yes, because these 2 trials have been conducted, about 75 in each trial, and they have been randomized using Crisacan twice daily. And this is the first trial and this second trial, and they have been used as a ISGA, Investigator Global Assessment, which is classify atopic dermatitis to clear or almost clear 0 and 1, and mild, moderate, severe 2, 3, 4. Let's see our result of these trials. The first trial, they show that about 32% have been achieved to be clear or almost clear within 1 month. At the end of the study, 29 have been incomparable to the emollient-rich vehicle. And the second trial, also comparable results. The patients that receive to 0 or 1 with using the ESGA, the 31 comparison to 80% of emollient-rich vehicle. So the percent of patients that clear, almost clear, more than half of the patient of the first trial and also the second trial with Crisacan, they are 0 or 1 clear or almost clear at the end of 1 month by using Crisacan BD4 inhibitors. And there is marked reduction in the erythema, exudation, excoriation, induration, and lichenification at the end of 1 month. There is a new study have been conducted among Chinese and Japanese patients in 2023, and they have been used Crisacan for 1 month and follow up for another 1 month twice daily. And the result also comparable. The patients that show improvement that reaching clear or almost clear, they are about 41% versus 28, and the patients that receive success, 0 or 1 with 2 grade improvement of the score have been also significantly improved. What are the indirect clinical benefits? So we can improve the patient quality of life, we can improve the patient sleep with the use of the BD4 inhibitor Crisacan. This is questionnaire have been conducted about the sleep outcome in those patients using Crisacan, and they asking about how much has your sleep been affected by your skin problem. And we can find in the Crisacan is about 51% have been sleep disturbance have been reduced in comparison with the vehicle. And when we asking about how many nights has your child sleep have been disturbed, we found that at the end of 1 month, 71% of those patients that using Crisacan, they have no problem with their sleep at the end of 1 month. Also, the quality of life of our patient with atopic, with the use of Crisacan BD4 inhibitor, they improve indirectly through improving the pruritus, and this is the mainly effect, indirect effect, and direct effect by improving the eczematous lesion on the patient with atopic dermatitis. When does pruritus relief start with the use of Crisacan? When the patient becomes free from pruritus. With the use of Crisacan, usually there is early relief of pruritus. It can be started in day 2. The severity of pruritus have been reduced starting from the day 2 and about 24% and increased to at the end of 1 week to 41%. This is a marked relief of pruritus, just about 40% in just 1 week of starting a treatment. And how many patients become itch-free? At the end of 1 month, about 30% of patients using Crisacan become itch-free. So how we can predict the early responder to Crisacan, so I can prescribe freely to this patient and I can expect that early response. This is a regression analysis of the 2 pooled studies. They refer that younger age of patient, white races, moderate baseline, not receiving prior AD treatment, and this duration shorter, and not concurrently using antihistaminic. All these personnel are candidate for early response of Crisacan to this patient of atopic dermatitis. So, is Crisacan suitable for sensitive area? This is very important because we can prescribe this agent of treatment to many patients in the sensitive area affection. Yes, we can say that it is suitable for sensitive area. And this is a clinical study have been conducted for 3 weeks among healthy volunteers. They have been tested about 13 anatomic regions that we showed in the shape. And we can say examine the burning, stinging, erythema, and pruritus after the use and compare this with the vehicle, and they found that they can be very well tolerated in sensitive area and they can safely use. Is Crisacan effective in treatment experienced patient? This means that if I prescribe previously the patient is topical steroid or TCI, topical calcineurin inhibitor, I can shift this patient to the Crisacan or not, or this will affect the result of Crisacan. We found that the use of previous treatment of systemic corticosteroid or even TCI, they have no impact on the effect or response of Crisacan, and even the treatment naive, they have a higher response of Crisacan to their improvement of atopic dermatitis severity. Also, this is comparison. If the patient of atopy have been associated by one of the what we call is atomic march, with complicated sometimes with allergic rhinitis, allergic sinusitis, bronchial asthma. Is Crisacan is effective in treating this patient? We found that there is no defect in the response of Crisacan, whether the presence of allergy or not, allergic rhinitis or not, asthma or not, food or not allergy. So Crisacan can be effectively act in reducing atopic dermatitis associated with other atopic comorbidities. What we do if we have a younger age, less than 24 hours to 24 months, such patient we can have. Some patient they have 5 months, they have suffer from pruritus, redness, itching, and crying, and diagnosed with mild atopic dermatitis. Usually we are dealing with this patient and writing off-label treatment, because most of the modalities of treatment, they are not FDA approved for treatment such kind of age. But what about Crisacan? The PD4 inhibitors, there is a clinical trial have been conducted about this young age from 3 months to 24 months, and they have been proved to be effective at the end in 1 month. Is Crisacan good for flare, reducing the flare? Yes, it can reduce, because we know that some types of mild or low potency topical steroid and some of TCI can be used as a proactive or long-term maintenance therapy with certain limitation. This is a very longitudinal study, have been used Crisacan for twice daily for 2 months, and then follow up for the flare by using it once daily for 1 year, and then follow up for 1 month. And during the flare, we return back to use Crisacan twice daily. But during this 1 year, we use once daily at the site that frequently exacerbating. And we found in the long maintenance that the flare-free days have been improved with the use of Crisacan once daily. And also the number of flares have been significantly reduced by use of Crisacan just once daily. What about safety? Usually we are concerned about safety, especially when we're dealing with the children. Only local complications have been in the form of pain at the application site, discomfort, and erythema have been reported with the use of BD4 inhibitor Crisacan. And there is a 2-year animal study testing the carcinogenicity and tumorigenic activity of Crisacan, even in use in higher concentration, 2, 5, and 7% for 2 years with no proved any tumorigenic activity, although there is some TCI have been linked with the lymphoma in these animal studies. Crisacan versus topical corticosteroid, which are still in our guidelines, is a very mainstay, but we have to use very low to mild potency steroid in this patient with atopic dermatitis, and it can be not used for long period because of we know the local side effects of topical steroid, especially if we misuse of very high potent or potent steroid on those patients for long time. Also, the TCA, they have been approved for short-term treatment of topical calcineurin inhibitor. Sometimes they have been associated with burning, stinging, and still we have some concern, especially from the FDA, about the animal carcinogenicity studies that share that TCI have been associated with increased incidence of lymphoma. This is a comparison about the pooled study of IBD individual participant data. They show that improvement of Crisacan with atopic dermatitis was the same or higher than the improvement with mild topical corticosteroid or TCI. At 2016, FDA approved crisaborole for eczema atopic dermatitis, and the extent as 2020, the extent of FDA approval starting from 3 months, and this was a breakthrough in the treatment of atopic dermatitis because the age is become from 3 months up to 24 months have been released. We must remember that pimecrolimus TCI and the tacrolimus 0.03 only approved for more than 2 years, and tacrolimus 0.1 approved for more than 16 years old. And we know that the FDA boxed warning to TCI in 2006 and 2011, and still now not released or correcting the concern about the use of TCI and the lymphoma. Also, there is a big, very clinical study, systematic review, including many clinical RCT studies. They share there no effect of lymphoma with the use of TCI. Still, the FDA insists to this boxed warning. So we can say that Crisacan ointment is a non-steroidal offering BD4 inhibitor that have been approved to treatment of mild to moderate atopic dermatitis starting from the age of 3 months. They have no limitation, can be used for sensitive skin area, and can be used in the long-term maintenance and reducing the flare of patients with atopic dermatitis. And this is a recent American Academy of Allergy and Asthma Immunology American Colleague of Allergy recommendation. They recommend the use of BD4 inhibitors Crisacan, provided that the severity, we must only include patients to mild to moderate. We cannot use this for severe patients with atopic dermatitis. And this is especially offered for patients they wish to use alternative to corticosteroid because of the safety concern. So this is important clinical tip. When we use Crisacan, before or after emollient, because emollient is the mainstay of treatment of our patients with atopy. And this is an ex vivo study that demonstrates that the best time to apply Crisacan is the 15 minutes before using the emollient. Because if you apply immediately after the emollient, or even after you apply the emollient first and then apply Crisacan, this will impair and decrease the about 2 or 3-fold decrease in the concentration of the Crisacan into the skin. And this is some clinical cases have been treated with Crisacan at day 1, day 8, day 22. Another patient. One month. Another patient with marvelous result in the hand, because usually hand eczema is very hard to treat. And this is our take-home message. That Crisacan is indicated topical treatment, mild to moderate atopy for patients younger than 3 months, twice daily. Thank you.